And now I want to turn the first plenary over to my colleagues. Come on up. Lisa Bateman and Elizabeth Donner. Elizabeth is from Toronto, sick children in Toronto, and Lisa is from Cedars-Sinai in Los Angeles. They are longtime PAME friends, and happy to turn them over to you guys.
Okay. Good morning. Wow, that was such a great way to start. All I want to do is keep talking about data and lack of data and how important the American infrastructure has really been. You heard I'm from the Hospital for Sick Children in Toronto, University of Toronto, and so I feel I do have a lens on how important it has been for the international community, the information that's come out of the U.S., and that it's really a challenge for the whole world when we see that dry up a bit. So, but that's not what I'm here to talk about. I just feel very passionate about what you were just speaking about. At the heart of everything we do at PAME is prevention. We are all here from different perspectives, but with a strong focus on how we can save lives. And I hope that every PAME meeting results in us moving forward in that way. And so Lisa and I and the whole planning committee felt very passionately that we should start out the day talking about prevention, reducing risk, saving lives, and advancing prevention of epilepsy-related deaths. So we have a group of speakers here today, and what I'm going to do is I'm going to introduce our speakers, and they can join us on the platform, and then each one of them will have an opportunity to speak, and then at the end we have time for questions. And let's see. So our first speaker will be Julie Lazzara, and Julie is the president of Landon's Legacy Foundation, which is a nonprofit dedicated to making our community safer and more accessible for those with disabilities or rare diseases. Landon's legacy was started in memory of her son, Landon. Really, Julie draws on her background as a professor of psychology and brings that unique understanding of human behavior and learning to the critical area of emergency preparedness, especially for vulnerable populations. So Julie's joined us on stage. Our next speaker after Julie will be Dr. Nicole Odom, and I welcome Nicole to come on up. She's an assistant professor of neurology at the Geisel School of Medicine at Dartmouth, and her clinical and research interests focus on improving survivorship and reducing disparities among people with epilepsy, particularly in rural populations, and really advancing her passion for equitable epilepsy care. And Nicole will be talking about accidental causes of mortality in people with epilepsy. Dr. Mary J. Pugh will follow Nicole. Dr. Pugh is a professor in the Department of Internal Medicine at the University of Utah and a research health scientist at the VA Salt Lake City Ideas Center for Innovation. She uses large national data sets from the VA and the Department of Defense to identify risk factors and develop strategies to improve care and reduce adverse outcomes, including mortality, in vulnerable patient populations. I'm really excited that she's able to join us today because I feel like her focus on the veteran population is not something that we've had a view on before at PAME, so thank you for that. And lastly, Dr. Ben Tolchin will join us. Dr. Tolchin is the director of the Yale New Haven Health System Center for Clinical Ethics and an associate professor of neurology at the Yale School of Medicine. His research has been recognized with many awards, including the Young Investigator Awards from both the American Clinical Neurophysiology Society and the American Epilepsy Society. And Dr. Tolchin is going to present on driving and mortality prevention in epilepsy, including updates on new recommendations from professional associations. Again, a really important lens with his ethics background that we haven't always had access to before at the PAME meeting, so really important for us. So I will invite up our very first speaker, Julie, to get us started. should have done that. Sorry, that's bad. Okay, next.
There we are.
There you go. There's Landon. Thank you,
Thank
Julie.
you. Good morning. While I appreciate the opportunity to speak with you today, there's someplace else I'd rather be. And that place is at home with my son and with our family. Standing here before you means that I'm a bereaved parent to a child that had epilepsy. If the epilepsy diagnosis wasn't devastating enough, my son's death was preventable. Speaking on behalf of the bereaved family members here impacted by epilepsy, we're not here because we want to be here. We're here because we have to be here. There's no making sense out of our loved one's death. It didn't happen for a reason. We carry their message forward while we still have our voice. While our new mission doesn't erase our pain, it does give us a new purpose. So this is Landon. So a little bit about Landon's condition and a little bit more about him. So at 4 months old, he had his first seizure that we recognized. And after going to the hospital, we were told that he had focal cortical dysplasia, but not to worry, his seizures could be managed. He was a candidate for surgery. He did have a resection of the part of his brain, his frontal lobe part of it, and he had a VNS implant, but he was never seizure-free. He had moderate control with his seizures. His epilepsy was intractable. He did have infantile spasms and later was diagnosed with Lennox-Gastaut syndrome. But even though he was very slow to develop, he did develop, and it was so beautiful to see. So at 1 year old, he was, when most kids were walking, he was sitting up for the first time. And at 2, he started crawling. And at 3, he could stand. And at 4, despite all the odds, he was walking. And he started communicating on a communication device. He went to school. He gave the best hugs. He loved bubbles. He was nonverbal, but he spoke so much in what he didn't say. He really was a joy to our family. So one day, our day started with sending Landon to school, and he never came home. Landon had been in school for 1.5 years. This was his first day of summer school in developmental preschool. We had met with his teachers and staff. He had an updated IEP. We went over a seizure response plan. We thought he was in a safe place with people who were equipped to care for his basic needs. Those in the classroom did not perform life-saving measures for a choking incident. By the time that EMTs arrived, too much time had passed, and he could not be resuscitated. Which led our family down a little path of research and asking ourselves, are schools equipped to handle medical emergencies? The simple answer is no. Finding out some of these statistics were shocking to me. I'm curious if they're shocking to you, but only 4 states in the US require a teacher to be CPR AED certified. And when speaking to friends and family, people just have the assumption that of course they are. They're not. 14 states require having at least one AED on campus. And most of the time, it has to do with sports. Really, the focus is on athletes and in sports. And then, as far as nursing, this was also shocking, that only New Jersey mandates a certified nurse for every school building. Most schools, there's one district nurse, and then there's health assistants at different locations. And these are including schools that have medically fragile kids that are there. So while the seizure support and safety legislation that's going on right now is very important, What I want to say is it needs to be supported by better emergency medical preparedness. We're teaching people how to react to seizures, but they don't even have the basic life-saving skills of the abdominal thrust and CPR. So without that, I just think it's a very scary place. So what our call to action, this is actually my daughter here at one of events that we've had, that those caring for the medically complex must be prepared with emergency response training. They should be CPR, AED trained, and have the seizure first aid training as well. As many of you know, permanent brain damage begins only after 4 minutes without oxygen, and death occurs soon after that. And when I looked up the average response time for paramedics to arrive on scene in the US, it's 7 minutes. So what does that tell you? So in our grief, we founded our nonprofit, Landon's Legacy Foundation, and our focus really is on trying to have a more safe, accessible community for all, and especially those with disability. Everyone deserves to be saved in an emergency, but especially our epilepsy community, those who are medically fragile, need to have a chance if something goes on, and people around them, the bystanders, are not always ready to act. So thank you so much for your time.
Thank you so much, Julie. I think that was a perfect way to start, really, with a strong focus out on prevention. But most importantly, thank you for sharing Landon's story with us. I will now welcome Dr. Nicole Odom. I should say we're doing questions at the end, so we'll have plenty of time. If any questions strike you, you have cards on your table, you can jot them down, we'll pick up the cards, or you can just use it as a memory jog to remember what you wanted to ask.
Is this the green thing?
Green
here?
button.
Okay.
I did not get a print.
Oh, and I can see it down there.
Yeah,
Okay.
try and make sure it's
Okay.
your slides.
Yes, thank you. Okay. Good morning, everybody. It's a true opportunity to be here. Thank you, Julie, for that story. So accidental causes of death in persons with epilepsy also deserve dedicated attention, as Julie so eloquently demonstrated with her story. So including accidents such as respiratory complications, choking, drowning, burns, falls. These are the types of accidents that I'm going to be focusing on today. This is the outline for my talk. I'm going to briefly reiterate the significance of this issue for these particular accidental causes of death, and then review the available data regarding who may be at higher risk and some ways that we can improve safety specifically for this population, and then touch briefly on some future directions and research that I'm involved in. So very briefly, these are all studies that highlight and reiterate the significance of this problem, and especially accidental causes of death. So the paper on the top left, published in Brain, was looking at cause-specific mortality and life years lost in people with epilepsy. It was a Danish cohort study. And what they found was that individuals with epilepsy were more likely to have reduced life expectancy by roughly 10 to 12 years, but importantly, individuals with epilepsy were more likely to die of all causes. So for example, individuals with epilepsy were more likely to die of infections. The study on the far right, characteristics of deceased subjects transported to a postmortem imaging center due to unusual death related to epilepsy, showed that not only individuals with epilepsy were more likely to have unusual causes of death, but as you can see by this bar graph, even after postmortem imaging, they were still more likely to have unspecified causes of death as depicted in the white bar graph at the top. And then lastly, the bottom paper, the main take-home point of this was that individuals with epilepsy were more likely to have accidental causes of death by 3 to 4-fold compared to the general population. So, as Julie already demonstrated much more eloquently, this is a significant problem, and we need to do better. We can do better. But how do we walk this fine line between safety and autonomy? So as an epilepsy provider, I want all of my patients living with epilepsy to do everything that they want to do. I want my friends with epilepsy to do everything they want to do. And so we have to navigate trying to maximize safety while also allowing autonomy. And so perhaps looking a little bit closer at those who may be at increased risk and in what settings will help us tailor our counseling and interventions. Sorry, I forgot to relay the key points. So to summarize the first part, mortality from all causes is increased in individuals with epilepsy. There's a higher risk of experiencing uncommon causes of death, and individuals with epilepsy have a 3 to 4-fold increased risk of accidental death. Okay, so going into those that may be at increased risk. This was a nice paper that was performed in Stockholm, so a developed area. And just to orient you to the slide really quickly, the blue line at the top is the reference population without other health-related issues or comorbidity. The line closely following that is epilepsy cases without comorbidity. Then there's a pretty big drop between that and the line that you see sort of in the middle, the red line. That is the reference population with other health-related issues, followed by epilepsy cases with comorbidities. And as you can see that the yellow line at the bottom, there's a fairly large gap, especially within the first 2 to 2.5 years after the first incident seizure, that this is really a high-risk time for these individuals, and especially those with other health-related issues. So as I was preparing for this talk and thinking about my own experiences, I learned that a patient of mine recently passed. So she was a vibrant lady who had type 1 diabetes, and as a complication of this, she had peripheral neuropathy, so she couldn't feel her feet very well and had frequent falls, which is actually how I came to meet her. She had a fall and had a traumatic brain injury and then developed post-traumatic epilepsy. So I saw her frequently. We talked about the importance of taking anti-seizure medication, driving in our state, but I didn't spend a lot of time focusing on falls in particular. She was in physical therapy, but I regret this. She ended up falling recently and passing as a result of that. So it was a reminder as I was looking through, other health-related issues, why people have seizures or develop epilepsy to begin with, and really the fact that we as a community need to really think about our patients holistically and the risk factors that they may have. This was a systematic review looking at many papers globally and in mortality in persons with epilepsy. And in doing so, they were able to really identify differences in particular regions. So the blue bars represent the developed regions, and the green bars represent the underdeveloped regions. And as you can see with this slide, so in underdeveloped regions at the top part of the chart, accidents such as suicides, drowning, falls are more likely, whereas those in developed regions at the bottom, comorbidities or other health-related issues like strokes, cardiovascular disease, in addition to respiratory complications like what Landon experienced, are more likely. And this study took it a little bit further, so they actually offered ways to counsel depending on these different risk categories. So, for example, epilepsy patients within the first 2.5 years treat the underlying causes and encourage earlier interventions. Patients with uncontrolled seizures prepare for CPR. In high-income countries, maybe we should focus more attention on other health-related issues, whereas though in low-income or rural areas, strengthen education. So this was really nice that there was this recommendation for how to counsel depending on what an individual's risk, but perhaps we could push this a little bit further. For example, this was a study that was done in the region of rural Bangladesh where there is frequent flooding, and what they showed was that the injury-related deaths among people with epilepsy in this particular population were much more affected by drowning. So if I were a provider in rural Bangladesh, or I'm seeing someone who loves to swim or lives near the water, perhaps I could tailor my counseling a little bit more specifically for that context. This is a Hayden matrix. So this is a Hayden matrix on drowning, but Hayden matrices exist for all types of injuries and death, including choking, falls, and it's nice in that it looks at personal and then agent or vector attributes in addition to the social environment before, during, and after an event with levels of evidence as far as what interventions may be most effective. So just one example, drowning. So something personal that someone can do to help prevent is to learn how to swim, for example. From an equipment standpoint, friends or people around them can role model life jacket use. The physical environment, we could encourage swimming where there are lifeguards. And lastly, for the social environment, mandate four-sided residential pool fencing. So this is all to say that there's no really one-size-fits-all in terms of how to prevent any one particular injury or death, but really it's a collective responsibility amongst all these layers that can really help to reduce injury and improve safety. So to summarize, those individuals who are at higher risk have uncontrolled convulsions, other health-related issues, really within the first 2 years after diagnosis, and then there are those who are in high-risk environments. And then safety is a shared responsibility. It's both individual and region-specific, and it's important for all of us to get involved. Sort of preaching to the choir here, that's why all of us are here, is because we're getting involved. But one of the ways that I am hoping to become more involved is through research. So this is a study that I'm working on with the generosity of the Diamond Clinician Faculty Research Award with the inspiration of Lindsay Schomer and our mentor, Dr. Lisa Bateman. And we've partnered with a data scientist, Nicholas Jacobson, who specializes in machine learning to understand those causes of mortality in our population and hopefully thereby reduce mortality. So some of you may know that Dartmouth Hitchcock is a level 4 epilepsy center, but we also happen to be in the middle of the woods. So we're the most rural academic center in the country. So our hypothesis is that factors that contribute to death in our rural population are unique, and we aim to determine the specific, or the leading causes of death in our population, and then those factors, both disease and social variables, that are most responsible for these leading causes of death. We're conducting a retrospective cohort study of patients who have died while being cared for at our center. Since 2013, all patients use a tablet-based questionnaire filling out disease and social variables. And we're hoping that this will provide a lot of information in the future. This is very preliminary, but just what we know thus far is that our population consists of over 8,000 individuals with epilepsy. It's roughly split between males and females. We have a wide age range. There are roughly 10% who are known to have died, and another 245 who are lost to contact, and this might be because they've moved away or they may have passed. We are still determining that. And then this is the chart that's, you can see here, is just some examples of the social variables that we can look at. So distance to our clinic, the social vulnerability index, and the social deprivation index, which have a number of subcategories beneath them based on both self-reported questionnaires in addition to census data, looking at things like housing or food insecurity, for example, and we can compare those variables to those who have died to those who are still living. So to summarize, individuals with epilepsy have increased risk for death from all causes. Accidental causes of death are especially important. The relative risk for these accidental causes are those with uncontrolled seizures within the first 2 to 2.5 years after diagnosis, those with other health-related issues. It can be region and environmental specific. It is our shared responsibility to help improve safety in these individuals, and future studies should focus on tailored risk assessment and effective interventions. These are my references, and that's all I have. Thank you all so much for your attention.
Thank you, Dr. Odom. That was an excellent way to begin discussions of accidental and preventable deaths. Our next speaker, Mary Jo Pugh. I'd like to invite her to come up and begin to speak to us about mental health.
All right. See if I can figure out the clicker. I'm good. So, good morning. Today we're going to talk about the impact of mental health, or things that I call brain health conditions, on mortality in people with epilepsy. And when we think about the risks of epilepsy, we usually focus on seizures. I imagine, if you think about it, what is a seizure? It's added weight. Life is difficult enough. You add seizures, that's a backpack. It's heavy, you can never take it off, and we know that carrying this pack makes life harder and the path steeper. But recent research tells us that for many people, the seizures aren't the only thing in the backpack. There's a lot of stuff on the backpack. In this presentation, we're just going to focus on one piece of the things on the backpack, and that is how mental health conditions like depression, anxiety, psychosis, and PTSD are like invisible stones that weigh it down. We'll explore what I call dangerous math, where the weight of the conditions don't just add up, it multiplies the risk of premature death. But by unpacking these risks, we'll see that treating the mind is just as critical as treating the seizures, and how lightening that load can help save lives. So this is just an outline of our discussion. It's a very busy slide. We're going to start with looking at just the risk of mortality for people with epilepsy, how the double trouble of adding mental health and other brain health conditions makes that even more difficult, and then we'll look at kind of some of the things that might be in that relationship, and then look at what is it that we might do to address that. So we know that even without other brain health conditions, people with epilepsy have a 2 to 3 times higher risk of early death than people without epilepsy. But these multiplier effects that I kind of referred to previously are these brain health conditions make premature death even higher for some people than others. We also believe that there are things that we can do to mitigate that, so that's a hopeful piece that we can talk about. So when we look at the relationship between epilepsy and these psychiatric brain health conditions, you can see it's pretty complex. Frequently, it's bidirectional, where one thing causes the other, and then having that causes, for those who don't already have it, can cause additional in other people. And these brain health conditions affect quality of life and treatment outcomes. The psychiatric disorders occur in about 1 in 3 people, sometimes more, sometimes less, depending on the specific population. But this rate is a rate 2 to 5 times higher than the general population. And that's due to some shared neurobiological mechanisms, psychosocial factors, and environmental factors. So we look at, I don't know if I can do, I can't. I'm incapable of doing the laser. So depression is the most common of these. It affects about 25% of adults with epilepsy, and a history of depression increases the risk of epilepsy, and epilepsy increases the risk of developing depression. Why this happens is complicated. It's due in part to dysregulation in the brain neurotransmitters, increased cortisol due to stress, inflammation in the brain, and psychosocial factors that occur with seizures and stigma. It's also important to know that depression is the strongest predictor of poor quality of life and increases the likelihood of suicide. Next, we go to anxiety disorders, or worry. It's really underdiagnosed, so it's really hard to say what % of people with epilepsy actually have anxiety, but estimates are between 20 and 50% of people with epilepsy have anxiety. High anxiety levels are related to more seizures and social isolation, which then gets into a negative cycle of more seizures. In addition, substance use disorder is more common in people with epilepsy than the general population. Some people may use substances to self-medicate the anxiety or depression. Seizures may be caused by withdrawal. Substance use may lead to missed medications and other metabolic disturbances that provoke further seizures. And then we have PTSD. PTSD is common. People think about that as common in the veteran population and those with traumatic brain injury. So TBI is traumatic brain injury, may lead to seizures. Seizures may lead to TBI because you have a seizure, you fall, you hit your head. However, experiencing those uncontrolled seizures also is a traumatic event that may lead to PTSD, and it's something I'm not sure that we think a lot about, but I think we need to think more about that. And finally, while schizophrenia and psychosis are not as common as depression, it has an enormous impact on quality of health, quality of life, health status, and mortality for the fewer people who have that condition. So let's talk about the weight of the backpack. Let's start with case study. So imagine a young woman named Elena. Elena lives with epilepsy. To visualize her condition, imagine that everywhere she goes, she has this hiking backpack, and inside this backpack are her seizures. They're heavy, unpredictable, and require constant attention. Because of the backpack, Elena's walk through life is already steeper than most. Statistics show that carrying this epilepsy backpack makes her mortality risk increase 2 to 3 times than her friends who walk without one. She has to be careful of falls, careful of her medication, careful with her sleep, careful with reducing stress of everyday life. But the literature tells us that for many people like Elena, the seizures aren't the only thing in the backpack, as we can see. We start with the first hidden stone is anxiety and depression. Over time, Elena starts to feel isolated. The unpredictability of her condition makes her anxious. The burden makes her sad. This is common in about 1 in 4 people experiencing depression and even more experiencing anxiety. When depression enters the picture, it's like a heavy, invisible stone added to her backpack. But here's the critical danger. The weight doesn't just add up, it multiplies. When Elena's depressed, she's less likely to take her medication on time. Missing medication leads to seizures. More seizures make her more depressed. It's a vicious cycle. This is the most alarming part of the story is the potential for suicide risk. While Elena's risk for suicide is already higher because of epilepsy, adding depression or anxiety causes that to skyrocket 12 to 32 times higher than the general population. The stone of depression and anxiety make that path seem insurmountable. Now consider a different character, a young man named Marcus. Marcus has epilepsy, but he also has and struggles with schizophrenia. This combination creates a fog that makes life navigating the issues of epilepsy not only stressful but dangerous. The literature calls this combination of epilepsy and schizophrenia alarmingly early mortality. For Marcus, the risk of dying prematurely is about 13 times higher than the average person. And the most critical danger zone is in young adulthood, between the ages of 25 and 50. The medication for his mind and the medication for his seizures can sometimes strain his heart, leading to cardiovascular disease. And the fog that the medications and the brain disorder cause makes it hard to distinguish reality, increasing the risks of accidents and suicide. And then we turn back to Elena. To cope with the stress of her condition, she might reach for a drink. It feels like a crutch, something to lean on. For someone with epilepsy, alcohol isn't a crutch, it is a trap. There's a feedback loop. Alcohol changes the brain's chemistry. When the alcohol wears off, the brain sometimes becomes irritable, often triggering a seizure. And the outcome to this is unnatural death, such as poisoning, accidents, or falls. If Elena misuses alcohol or other substances, her risk of dying is nearly 5 times higher than if she didn't have epilepsy. And now we're going to turn to my population of interest, which is veterans. We meet David, who returned from service, had a traumatic brain injury, and later he developed post-traumatic epilepsy. David is what researchers and clinicians call double vulnerable. And one of the big issues is he has impulsivity and cognitive challenges potentially from the brain injury, combined with the unpredictability of seizures. He's 3 times more likely to develop severe anxiety than other brain injury survivors. And this combination makes him highly susceptible to accidents and mental health crises. In fact, our recent research has examined phenotypes of comorbidity in veterans with epilepsy and found 6 distinct phenotypes. Many of those were associated with mental health. I'm going to see if my changes didn't take. Anyway, so we had six phenotypes. One was just relatively healthy. About 40% of the cohort was relatively healthy. Another, there were PTSD. There was one that was focused primarily on PTSD, one that was depression and anxiety. And these were looking at comorbidities 2 years before a diagnosis of epilepsy and 2 years after, and the year of epilepsy diagnosis as well. And so we have depression, anxiety, PTSD. There was a bipolar substance use one. And I don't think we talk about bipolar disorders so much. We talk about schizophrenia, but bipolar is very prevalent, at least in the veteran population, the young veterans. And I think it's more prevalent in the younger population in general, but I think we need more research to examine that. And there was a chronic disease group that were just a little bit older, had a lot more heart disease, hypertension, that kind of thing. And then there was a polytrauma triad, which is comprised of TBI-related stuff, mental health, depression, anxiety, PTSD, and then pain-related disorders. And they also had a bit of chronic disease, kind of the cardiovascular disease, hypertension, a lot more sleep apnea than the other groups. And so what I think that clustering of these symptoms before and after epilepsy, looking at trajectory, suggests that we can't look at epilepsy as a single thing. We need to look at the complex comorbidities that come in with the patient. And it's really all in that backpack. And we start adding even more stones to that backpack. You have to think about the impact of that on the patient, the person with epilepsy, the family, their friends, the place where they work, and then society in general. And we need to be very cognizant of that. So why does this combination lead to higher mortality? The story ends with 3 main threats, and I would actually add a 4th, which I will. But primarily people think about suicidality, at least in adults. And this is maybe when the emotional burden becomes too heavy to carry, maybe with relationship issues that surround the burden of seizures and brain health conditions. It might also be associated with impulsivity and other life situations. External causes, we just heard a lot about external causes. But when you factor mental health into that, you may have missed medications, not seeing things due to distraction, with resulting fatal accidents such as drowning, falling, and car crashes. And then SUDEP, sudden unexplained death in epilepsy. This is a physiological threat. When depression and substance use or other conditions cause somebody to miss their meds, lose sleep, or have more breakthrough seizures, you end up having a small risk of heart or breathing simply stopping, and more seizures make more risk. And one thing that I don't think we consider is some of these medications for seizures and the other brain disorders may lead in addition to all the mental health, may lead to cardiovascular risk factors that in and of themselves increase mortality. In our study of veterans, we found that the highest cause of death, the highest cause of mortality was accidents. The second was suicidality and kind of overdose mental health related things. And the third was cardiovascular disease. And this is in a cohort where the mean age was 44. And so this is something that I think deserves a lot more research, but it suggests that we might need to be thinking of not just the brain health, but cardiovascular health is brain health as well. It's one body, and we have to look at the patient holistically. The solution is to treat the patient, right? Treat the patient holistically. For years, doctors only asked Elena, how are your seizures? They only checked on the epilepsy backpack. But this suggests that in order to save lives, we also have to ask, how's your mood? How's your thinking? And we need to treat the mental health and brain health conditions and TBI with the same urgency as seizure. By lightening that total load of the backpack, we don't just improve life, we can help save it. So adding stones associated with brain health conditions like depression, anxiety, TBI, PTSD, and psychosis doesn't just add to the weight of the backpack or risk of premature death, it multiplies it. We also know that people with epilepsy have multiple invisible stones at the same time, like the veterans data that I discussed. This multiplier effect then creates a cycle that may intensify the effect on mortality. As illustrated by Elena, the stress of seizures and depression may lead to substance use, which may lead to more accidents and more seizures, forgetting to take medicines, and ultimately early mortality. Marcus's stones are more complex, but one way to approach his stones is to assess his symptoms frequently, address the need to take medications regularly, both for the brain and the seizures, and address cardiovascular health needs early because the people like Marcus are at the greatest risk of cardiovascular problems. For people with TBI like David, we need to monitor symptoms of anxiety, depression, and PTSD, but we also need to assess the sequelae of TBI, like impulsiveness and substance use. And impulsiveness has tremendous impact in every type of behavior that we can imagine, including taking medications, doing things that a person with epilepsy shouldn't do. And we need to proactively address cardiovascular health and prevention. So these three biggest causes of death, accidents, death by suicide, and cardiovascular disease, and the cardiovascular disease itself might actually be SUDEP that's not coded correctly. And we've talked about this previously, and something that needs more research and more evaluation. And other significant causes of death include neurological disorder types as well. But these suggest that we need to focus not just on the seizures, but on the whole person, their mental health. And their mental health is not just mental health, it's associated with other physical health conditions as well. So we need to ask about the mood, ask about the things associated with seizures like mood, substance use, and quality of life. And we know that the field really values asking about mood and the seizures and the quality of life because there are AAN quality measures to recommending the use of these screening protocols at all visits. But we also need to consider how all these invisible stones affect the whole body, including cardiovascular health, because that's how we will reduce mortality or early death. And that's all.
Thank you, Dr. Pugh, for that excellent talk. It's interesting that a lot of your visuals had little vehicle crashes on them because our final talk is going to be Dr. Tolchin talking about the ever popular discussion of driving.
So I just want to express my pleasure and honor in being part of this panel discussion involving clinicians, researchers, and especially a family advocate, and this larger plenary, including so many different disciplines and so many different perspectives. It's really an honor, and I just want to express my gratitude to Lisa and Elizabeth, to PAME, and to you all for participating in this. I'm going to be focusing on driving and mortality prevention in epilepsy. And I think if there's one key takeaway point that I want to leave you with, it is that most individuals with epilepsy can achieve safe driving with appropriate medical supervision and management. At the same time, this raises a difficult balance of the individual driver's autonomy and quality of life balanced with their safety and public safety. And this is an issue that society, governments, and regulators have been wrestling with since the beginning of the 20th century. Starting in 2021, the American Academy of Neurology, the American Epilepsy Society, the Epilepsy Foundation of America, the Child Neurology Society, and the American Neurologic Association came together to try to develop a consensus position statement on balancing these concerns in driving licensure for individuals with seizures. And the position statement was published in March of this year. And I'll try to talk a little bit about the targeted evidence review that these organizations conducted as part of that position statement, and then some of the key recommendations that came out of that position statement. So to begin with, a key finding is that there is, in fact, a modestly increased risk of motor vehicle accidents associated with epileptic seizures, and that increased seizure frequency is associated with higher risk of motor vehicle accident. At the same time, serious fatal motor vehicle accidents are not statistically more common among individuals with epilepsy than among the general population of drivers, and in fact are significantly lower in comparison to drivers with alcohol use disorder, younger drivers, older drivers, or distracted drivers. So in fact, drivers with epilepsy are actually at lower risk of fatal motor vehicle accidents than many other populations of drivers who are significantly less regulated than drivers with epilepsy. Importantly, there are a number of studies showing that the risk of recurrent seizures and motor vehicle accidents for individuals declines with longer seizure-free intervals prior to driving. So the longer somebody waits and remains seizure-free before they begin driving or return to driving after having had a seizure, the lower their risk for a recurrent seizure and the lower their risk for a motor vehicle accident. And I won't go into the details, but there are a couple of studies that sort of show that waiting for 6 months, 12 months, even 18 months reduces the risk of a recurrent seizure and of a motor vehicle accident for an individual. At the same time, what we've seen at a population level, when states set mandatory seizure-free intervals, universal legal requirements for seizure-free intervals longer than 3 months do not appear to reduce motor vehicle accidents or motor vehicle accident fatalities. And this is based on 2 natural experiments, one done in Arizona in the 1990s and one done in Maryland in the early 2000s, where in Arizona, for example, the mandated seizure-free interval was reduced from 12 months to 3 months. And looking at the three years before that change was made and the 3 years after that change was made, there was not a reduction in motor vehicle accidents or fatalities per mile driven. And similar results were seen in Maryland. There is some speculation that this discrepancy between findings for individuals and universal state requirements may be because having more stringent, more burdensome state-level regulations prevents patients from sharing medical information with providers and increases the rate of non-adherence with regulations. Similarly, mandatory reporting by clinicians, by physicians, has been shown in study after study in epilepsy and in other conditions in the United States, in Canada and in several European countries not to reduce motor vehicle accidents or motor vehicle accident fatalities. But what mandatory reporting has been shown to do is to decrease disclosure of seizure information by patients to their clinicians and to increase the rates of unlicensed driving by individual drivers. Based on these research findings over the past 2.5 decades and some other findings that you can look at the position statement to see, we came up with several key consensus positions, and these were supported on a consensus basis by the workforce drawn from the organizations that I had mentioned, and were then reviewed and approved by the boards of directors of those relevant organizations. So first, that patients should work with clinicians to develop individualized treatment plans. Patients and clinicians should be aware of and follow driving laws in their state. Of note, the Epilepsy Foundation maintains a website with a directory of state driving regulations. I just have an example where you can look up individual states and actually compare between states. This is not necessarily a definitive database, but it is a good starting place to learn about driving regulations in a particular state and to compare between states. There's a key consensus position that prior to returning to driving after a seizure, states should mandate a seizure-free interval of 3 months, which can be extended based on individualized assessments by a medical advisory board. States should permit but not mandate reporting of unsafe driving by clinicians. And the federal government, states, and municipalities should provide accommodations, public transportation for individuals who are restricted from driving for medical reasons, and that these accommodations might include public transportation, ride shares, and self-driving vehicles in the near future. Just a couple of quick takeaway points. Again, most individuals with epilepsy can achieve safe driving with appropriate medical supervision and management. Motor vehicle accidents are slightly increased among individuals with epilepsy, but fatalities are not significantly increased compared to the general population and are actually much lower than among young drivers, older drivers, and distracted drivers. Mandated reporting has repeatedly proven ineffective in reducing motor vehicle accidents or fatalities, impedes open communication between patients and clinicians, and increases rates of people driving without a license. And prior to returning to driving after a seizure, states should mandate a minimum seizure-free interval of 3 months, which can then be extended based on individualized assessment by a medical advisory board. And with that, I'll stop and turn to the panel.
Thank you, Dr. Tolchin. That was incredibly helpful. We're going to take any questions for the panel. There are microphones walking around, and of course, those question cards. If you have them and you want to hand them over, we'll take them. I would like to take chair's prerogative and start. Yeah, can we turn on the table microphones as well? My question is for Dr. Tolchin. You've alluded to this, and because this is a conference on greater mortality, that all these driving restrictions lead to people basically lying to their doctors about their seizures and not being afraid to be restricted. And so how does that kind of impact the greater patient safety with respect to the other causes of mortality that we've just heard about on the panel?
Yeah, I think that a fundamental underpinning for any kind of public health measure, any kind of reduction in mortality in epilepsy is honest and clear communication between clinicians and patients, as well as families. And I think that it is essential to think that states and regulators and policymakers think about the impact of regulations on that communication when setting forth regulations. So a particular example is mandated reporting. There are currently, there's requirements for clinicians to report drivers in 6 states in the United States. There are efforts ongoing right now in California, one of those 6 states, to try to transition from mandated reporting to permitted reporting. And I think that's an example of a public policy intervention that could really enhance open, transparent communication between patients and their clinicians and support shared decision-making and thereby contribute to reduced mortality.
Can you turn the table mics on? Thank you very much. Sorry. I was just going to say, I think this so resonates with me about all our kind of mortality prevention and my work in Suit Up too, because it seems like what you're saying is we need to transition from this kind of duty to report more to a duty to educate, to really have people living with epilepsy understand where their risk is and how they can reduce risk to themselves and others, obviously, when it comes to motor vehicle accidents. So it really aligns really nicely. So thank you for pointing that out. I will also say, if you wrote your question on a card, put your hand up with your card and someone will come and pick the card from you. But I think Allison has someone with a question in the back.
Good afternoon.
I think we hear you.
We hear you.
Good morning. My question is for Dr. Mary Jo about the multiplier effects. I know you mentioned different ones. Is there any research, or do you see in the future, and maybe this may go to any of the scientists and researchers out there, a multiplier effect of autism and epilepsy? I know my son had both. And, I just don't see anything out about that, but I do believe that it's a piece in there with that. And so I just had that question for you, since that's kind of your wheelhouse.
I can say that I didn't search for those terms exactly, but I don't know of any literature.
Let's leave those mics on. Lean in. Try.
Can you? Okay.
Yes.
Yeah. Okay. Yeah, I think that's an excellent question and something I will like to look at myself.
Maybe we just, I don't know, maybe, okay. There's definitely, just as the only pediatric neurologist on the board, there's definitely an intersection between autism and epilepsy, where people with autism are more likely to have epilepsy and people with epilepsy are more likely to have autism. As far as an intersection with risk and mortality, I don't actually think that that's been very well looked at, but I would assume that some of the features of autism, Mary Jo, would layer on the way that you have, because we know that autism can be coexist with anxiety, coexist with depression. Some of the behaviors of autism could certainly complicate, and I see this taking your medications or pursuing other therapies, or even pursuing tests to get your epilepsy diagnosis if a person living with autism can't kind of come into the hospital, have an MRI, have an EEG. So I have to almost assume, based on your talk, Mary Jo, that that's going to layer on.
I agree, and think about both of those things. They're kind of brain health related, right? And I think kind of when we focus on specific diagnoses, think about bigger brain health, right? And they all fit, yeah.
We have a couple questions on, go ahead, and then we'll do the cards.
Okay, first of all, I'd like to thank the panel and just for all your commitment and, your push behind all of these issues. This really goes to Dr. Mary Jo, and I'd love to hear Julie's response to it too. I loved your analogy of the backpack. I just thought that was wonderful. As a parent advocate, are you finding that with that backpack, there's all these different disciplines. So there's the psychiatrist, there's the sleep apnea person, there's all these different drugs, and are they, we're lucky of where we live, and the epileptologist is kind of quarterbacking that, but I can't imagine that is the case. Are you seeing more cooperation with the different disciplines? Because I know there's liability and there's different things, and Julie, you probably had that experience too. How do you do you see more conversations and more consistency with those different, disciplines and the different drugs? I mean,
Yeah, so I know from the VA standpoint, if veterans get into the VA Epilepsy Centers of Excellence, it's a very multidisciplinary, it's like a level 4 epilepsy center. There's a good coordination. There's not the capacity for everyone to get there. And so it's like every other health system, it's a limited access situation. And I think there needs to be something healthcare related to address that, but I'm curious what your thoughts are.
What exactly do you want me to answer more to her? Yes, absolutely.
Yeah.
Yeah. I mean, you really are. You wear many hats, and you're really the one that's keeping track of everything and advocating for your child and just trying to let everyone know, especially, those caring for your kid, if you're not there, or whoever your loved one is, this is what their seizure looks like. Are you qualified to be able to handle it? What can you do? Yeah.
I have a bit of a follow-up to that, even just trying to bring Nicole in on the conversation too, because when you talk about, again, wearing my pediatric lens and working with families with kids with epilepsy, the parents' ability to advocate, and not because they don't have but there are barriers to being able to advocate. Those can be language, those can be time, all sorts of things. And so the parent's ability to advocate is so tied to the child's care. And I see you're nodding over there. I mean, that's such a powerful aspect of things. And I wonder, just when you look at mortality and risk in different environments, be they urban, rural, how that plays in, because I imagine it might be different depending in what kind of community you live in, what kind of work you do, whether you can find the time and resources to advocate for, and it doesn't have to be children, it can be people with adults advocating for themselves as well. So either to Nicole or Julie or both of you.
That's a really good point too about it's a privilege to be able to have the time to be able to advocate and to have the skills to advocate. And not everyone has that ability for their kids. And I feel like in our case, I tried to do everything. I tried to cross every T and dot every I and have him be safe. And I still couldn't save him. And that's difficult.
Yeah, I definitely agree that that's an excellent point. I think, we see individuals who come in with caregivers that really don't know them at all versus a family member who has, a binder of their health-related history. And one of the things that we're looking at with our study is not just those who filled out the questions, but also what questions weren't filled out or who didn't fill out the questionnaires. And through machine learning, hopefully that may tell us something as well. Are those individuals at increased risk if they're unable to fill it out themselves and the person who's bringing them isn't doing it either?
Thank you.
Thank you. We have very popular topics, some more questions for Dr. Tolchin. I'll give this one first. Is there any data on new onset seizures and motor vehicle accidents? Like someone's first seizure presents with a car accident.
I wrote that same thing down. I wanted to know.
There you go. Popular question, whoever in the audience put that one in.
Not direct numbers, but how often does because I see this sometimes in teens, does a motor vehicle accident actually lead to a diagnosis of epilepsy?
All right. So I think the answer is that's an area that needs further study. I don't think there is high quality evidence in that specific question of new onset epilepsy or first seizure of life leading to motor vehicle accident. I would speculate from clinical experience that the rate is particularly elevated compared to individuals with established epilepsy who, are engaged in medical management and who are aware of their diagnosis, but that is really based on my individual clinical experience and not based on high-quality evidence.
And then another question, really, I think this comes down to what you were saying before about individualization. There are questions about what about driving for people who experience nocturnal seizures and then other specific seizure types like someone with absence epilepsy?
Yeah, so if you're interested, you can take a look at the position statement that was published in Neurology in March of this year. We actually go through a number of specific characteristics, positive and negative features, positive features such as seizures occurring, an established pattern of seizures occurring only during sleep, or seizures occurring during a titration of an anti-seizure medication directed by a physician. Those would be positive factors, and those would weigh against extending that 3-month seizure interval beyond 3 months. On the other hand, there are negative factors such as seizures associated with a co-occurring substance use disorder, or an established pattern of non-adherence with medication. Those would be negative factors, and those would support an extension of that 3-month seizure-free interval by the medical advisory board. And if you're interested in seeing the details of those positive and negative factors, you can take a look at the position statement.
Can I ask a quick follow-up to that?
Yeah, for sure.
So with responsive neurostimulation and these devices that allow us to see seizures that may otherwise not be reported or clinically evident, how do you navigate that additional information?
So there is some really interesting emerging evidence. Hal Blumenfeld is looking at epileptiform discharges that do not have an obvious clinical correlate, so that are not considered currently as epileptic seizures, and looking at individuals on a driving simulator during bursts of epileptiform discharges. And in fact, is demonstrating that driving ability significantly decreases during these bursts, and the risk of a motor vehicle accident, at least on a simulator, significantly increases during these bursts. So I think there is emerging evidence that there are subclinical seizures and even bursts of epileptiform discharges that have thus far not been considered to be seizures at all, that may in fact impact driving ability. And so that is sort of an area of emerging evidence right now.
Okay, now I have a follow-up. Is there any data around other physiological states that impact people's ability to drive? Like, you might be able to do a study like that. Now, I don't know, I'm a neurologist, but in people with diabetes or heart disease or blood pressure changes or something like that.
I think there is growing attention to the impact of other chronic medical conditions on driving. I don't think it is as well studied as epilepsy. I think epilepsy has a long history. So the first reported motor vehicle accidents in the setting of an epileptic seizure go back to 1906. And as a result of this history, and as a result of certain very well publicized tragedies, there has been a lot of attention, both from researchers but also from policymakers. And so I think that there is more research around epilepsy and driving than other conditions, including other conditions which are probably more impactful on public safety, more negatively impactful on public safety. As I mentioned, young drivers, older drivers, distracted drivers are all at significantly higher risk of fatal motor vehicle accidents than individuals with epilepsy.
Thank you.
We do have a question back here.
Sorry, you're like in a back.
You're right in the light, Allison.
Thank you. Yes, please.
Thank you all and all of you gave an amazing talk today. We really appreciate it. I'm an epilepsy survivor. I also run a nonprofit called Empowering Epilepsy. When people ask you questions about everything that you've spoken about, the response is usually, well, you can advocate to your doctor. I'm curious, if we take every single talk that you just presented, and this was for a different diagnosis, like cancer or diabetes or something, all of those diagnoses they get to go and see different people about those things. That's already put into place. In epilepsy, that doesn't exist. The backpack is definitive of my life with epilepsy. I mean, that is what I was carrying every single day, but I was fine when I wasn't having a seizure, according to everyone else. The only way that we can make this move forward is if we put things into place, actions into place, so that people don't have to advocate for themselves only, but how do I know what I need to do to be able to get my independence back and drive? How do I know how to deal with the anxiety and depression of never knowing when having a seizure is going to happen? Does all of this make sense? What can we do?
Oh, I'll just say it makes amazing sense, and it's really a failure of the epilepsy community, epilepsy practitioner community to really address all the comorbidities or all the associated things that we see associated with epilepsy. We have a long history of not doing a good job of that, I think. Lots of colleagues in the room, hopefully they agree with me. I hope these discussions move it forward, but I completely agree with you.
I'll just say, I think I would agree with what Elizabeth said. I do think the Epilepsy Foundation of America and some of the local epilepsy foundations have been doing some really excellent work in terms of advocating around both mortality prevention and interventions in quality of life. And I really would encourage both clinicians and researchers and also patients and families to connect with your local epilepsy foundation and potentially with the national organization to engage in advocacy on a systemic level.
However, again, that's putting it back on the patients to do something. And I think, I don't disagree with you, of course, and I would say the same thing in my own jurisdiction, but at the same time, I feel like we have an obligation. I was talking to someone last night about the fact that when you're diagnosed with diabetes, you get to see a diabetes educator who explains to you about, sugars and insulin and all the different devices and all that stuff. And I hope that happens for the majority of people with diabetes. I know it does not happen for the majority of people with epilepsy.
I think you need a whole health approach. I don't know how feasible that is.
Yeah.
And that's exactly what you were, kind of talking about.
Thank you for labeling it.
Yeah.
Oh, yeah, okay. I do have one more card, but I will get to it. I don't want whoever wrote this to think I'm not going to get to it.
Hi. I really did also enjoy all of the presentations today. So my name's Amanda. I'm the Executive Director for Epilepsy Alliance Louisiana and the parent of a child with complex epilepsy. And so my question actually is a really kind of good follow-up to the last one of why are neurologists avoiding talking about these topics? My son has several risk factors for SUDEP, and I learned in a Google search, about it when he was actively having status seizure after status seizure. So I want to think about the way then that changed my relationship with that neurologist. And as the director, I've been in the room with adult neurologists, You guys were talking about patients lying to neurologists where they were saying, hey, basically lie to the patients about the driving laws in Louisiana because it's easier, It's less complicated. So are there studies looking at why neurologists are not having the courage that epilepsy patients are required to have? Because if they're in this room, they're statistically different than the ones who are not.
So I'm just going to address that right now. And as soon as it left my mouth, I wanted to slap myself in the face. But to the use of the word lying, that is very pejorative, and I apologize. But as Dr. Tolchin suggested, and also Dr. Pugh suggested, there's a lot of issues with communication, which is what you're getting to. There's definitely issues on our part, and part of the whole existence of this meeting and these people in this room is to try to improve these communication issues that you're talking about. I think I can go point at just about everyone in this room about, Did you hear about SUDEP? Who told you about SUDEP? Did you find out about it from Google? That kind of thing. I think there's also, both from the driving perspective and from what Dr. Pugh said as well, there's this tendency to focus, I'm your seizure doctor, tell me about your seizures, okay, bye. And that can be, we miss simple things like, are you having side effects from your medicine? Well, yeah, I'm not taking my medicine because it made me feel like I wanted to kill myself. Or it makes me feel so tired I can't function at my job. Or I wanted to go to a party and I knew I couldn't mix alcohol with my medicine, so I didn't take my medicine that day so I could have a glass of champagne at my sister's wedding. Or I feel overwhelmed, burdened, anxious, but you didn't ask me about that, So I think there is definitely an onus on us as providers to have that communication. And only if we do that as providers do the patients in turn have the capacity to tell us, hey, thanks, yeah, I haven't had any seizures this month, but I feel terrible on my medication. I lost my driver's license because I had a seizure last month. I can't get to work. I can't get to school because there's no public transit where I live and I can't drive. So I have to drive, but I can't tell you that I'm driving because then you're going to report me and I'm going to get in trouble with the law. And also this whole thing is stressing me out and I'm depressed and I'm anxious and I don't know how to cope with it. And communication is the number one part, and we all need to do better with it. As Dr. Donner said, it's a notorious issue that we tend to compartmentalize, be like, seizures, okay, next, and we don't think about my heart problem, my blood pressure, my diabetes, my mental health, and how all those things go together.
I also want to add that there have been actually a number of studies, mainly through surveys of neurologists and providers that treat epilepsy, asking the question, do you talk about SUDEP? There are some colleagues of mine in the room, we've done this work together. Do you talk about SUDEP? Why don't you talk about SUDEP? When do you talk about it? All that stuff. And some of the takeaways from that are, first of all, one of the big things we found in child neurologists through a study we did through the Child Neurology Foundation was that one of the top reasons why doctors don't talk about mortality risk to families of children with epilepsy is because they don't know enough. So if you knew less, you were less likely to talk about it. And so, in fact, some of our educational activities are really targeted to getting people comfortable with data so that they can talk about it. And that's something that obviously you would also do through your own organization and everyone here in this room. When we talk about it, people feel more comfortable about it. Because really, if you come to me in my office and ask me a question about some rash, my first thing is I'm not a rash doctor. I don't know about that. I'm not going to talk to you about your rash. If I don't consider myself knowledgeable about a topic, I'm not going to be comfortable talking to families about it. So that's one big takeaway. The other is a perception that that healthcare practitioners will worsen the experience of people living with epilepsy or their families or caregivers by sharing this information. And that's something that we, I think as a larger community through PAME and lots of my colleagues here have been working really hard to demonstrate that there's really no evidence that that sharing information about mortality risk increases significantly anxiety or changes significantly the behavior of people living with epilepsy in a negative way. So those are the two factors to answer your question really specifically.
And then we have a question here, and then we can round out with the question you have there. But I did just want to add, from my perspective, real quick before I hand it to my friend, as you were talking about communication as the theme, I would also add trust. So as a person with epilepsy, being able to talk to my provider and say, hey, this medication is giving me suicide ideations now because the levels are so high, we need to decrease it. Having that trust to be able to bring it up, know something will be done when you bring that up, but not bringing it up and then nothing's done. So I think adding to that communication, that trust factor with your provider as well. So I just want to toss that in before I hand it over to my friend Paula here.
Absolutely, that's an important perspective.
Thank you, Allison. Thanks to each one of you. This has been like being in college again. listening to you guys. But don't give any tests, please. You are awesome. I am a survivor. Well, I live with epilepsy. I have the DBS-3 on my brain. Unfortunately, I have done what you've said about some of us. I've had a few accidents. I've survived them, but that doesn't make me a champion. I want to know, is there a limit that you should place on yourself when you have several accidents that are kind of total, and how do you confront your family? How do you fight them when they're super overprotective and don't want you to drive again? Your independence and research for people with epilepsy too, with the cars that are driverless. Maybe we can get one of those.
Yeah.
I'll study for it and sit in it.
Yeah.
So do you have any answers or any response to any of that?
So a few things. One, just in terms of having a history of multiple serious motor vehicle accidents, unfortunately, that is, one of the sort of negative factors in predicting future motor vehicle accidents. And so that would be a concern, and that would definitely be something I would recommend discussing, with your physician. And I would have concerns about the risk of a future motor vehicle accident, particularly if there have been multiple prior motor vehicle accidents caused by seizures. And I'm so glad that you're here and with us and safe and healthy. And I would hate for, every time there's a motor vehicle accident, obviously it's a significant risk to you. And so that is a concern that I would have, and I would think that your physician would share. So that would be a real consideration in my mind if I was working with you. And I would recommend to you that you speak to your physician who knows you well about this issue. Your question about the driverless cars, I really hope, so this position statement was an update of a 1994 consensus position statement. And my sincere hope is that this will be the last position statement on this issue, because self-driving cars will render this issue moot within the next 5 to 7 years. There was an excellent op-ed in the New York Times yesterday about autonomous vehicles being an important public health intervention. That's true for individuals with epilepsy, but also many other medical conditions. There is growing evidence that autonomous vehicles are significantly safer than human drivers, and what the op-ed in the Times yesterday was advocating was that we should be aiming for 30 to 40% autonomous vehicles in the near future in order to reduce motor vehicle accidents generally. I would suggest, and this is not part of the position statement, this is my personal view that I'm expressing right now, that this would be a particular priority for the epilepsy community and for other communities that are affected by illnesses that potentially increase the risk of motor vehicle accidents.
One more question on the driving front, and again, this is along the lines of some of these other issues we've been talking about with advocacy and communication, providers and patients. In several of the jurisdictions you mentioned have mandatory reporting laws, and for those of you who don't know what that is, that means if I'm a doctor and I see someone who's had an episode where they lost consciousness, I'm required by law to fill out a piece of paper and send it in to the Department of Health or the DMV. Or if I don't do that and then something happens, I can go to jail, I can have to pay a big fine. So this is the kind of mandatory reporting crutch that's a bit on physicians. Not all states have this, some have more of a flexibility, as you said. In some of the states that have mandatory reporting, when there have been efforts to repeal the mandatory reporting, there have actually been backlash from physician groups and neurologist groups saying, hey, I feel safe because I just have to do this and then nothing's my fault, but as soon as you make it not mandatory, then it's totally my fault if this patient has an accident. How do we deal with that?
So I think there actually is a fairly simple legal technique to address that, which many states have implemented. And to be clear, there are only 6 states left that still have mandated reporting. California is a big one. 12% of U.S. drivers are licensed in California, so the fact that California has mandated reporting is a big deal. But the majority of states no longer have mandated reporting. What can be done very simply is to pass laws that provide legal protection for clinicians if they report or don't report, and that can address this concern that many physicians express about, well, if I don't report, then I'm legally on the hook and my license can be taken away. I might push back on that a little bit, but I think that there's a very simple legal remedy to that, which is to remove the mandated reporting and to explicitly put in law, and many states have done this, that physicians are permitted to report and permitted not to report based on their best clinical judgment and their interactions with that individual patient, and that they will be immune from legal liability, whether they make that decision to report or not report, so long as it's done sincerely on their best medical judgment. And many states have passed these laws, and I think that completely addresses and neutralizes that pushback that some clinicians have given.
One last question on a card that I've been holding for a little while. Okay, great. So this question actually has to do with how deaths are classified when a person with epilepsy dies. And the question is, if a person is driving and they have a car accident due to a seizure, is their death labeled as SUDEP? That's really kind of, it could be a straightforward question or a complex question. We know that how deaths get labeled has to do with how coroners and medical examiners evaluate deaths. So if a person has a seizure and then they have a car accident and the death is because they had a head injury due to the car accident or were fatally injured due to the car accident, then we wouldn't consider that as sudden death in epilepsy. But if their heart stopped kind of as a consequence of the seizure, that could be labeled as SUDEP, and a lot of that comes down to kind of how the death would be investigated, whether they had an autopsy and what the findings would be on that. So, and I think I'll just kind of close by saying that a lot of the topics we discussed in this question and answer period, including how we kind of categorize deaths and that, are actually addressed throughout the day. There's some great sessions where we're going to talk about counseling and how caregivers and doctors can talk about risk of mortality. So I hope everything that we didn't get to was going to be addressed through the rest of the day. And I will hand it back to Gardner to wrap up. Thank you very much.